So I'm going to talk about, mainly focus on the evaluation of seizures in infants and toddlers. And I think mainly, obviously, as a pediatric epileptologist, it's a challenge, but there's a lot of important issues in terms of making a proper diagnosis and also looking at appropriate treatments for children, and particularly infants and toddlers with epilepsy. I think many of the talks that you've heard are very important, particularly when it comes to sleep. Sleep in epilepsy in infants, it has a it plays an important role, and there's a lot of overlap with sleep disorders in children and infants at this age as well. The most important aspect that I really want to focus on is how to accurately make a diagnosis of seizures in children, and particularly in infants. How they are extremely different than the kind of seizures we see in school age or adults. Also, more importantly, that there are forms of seizures or epilepsy we see in young infants and toddlers that is often self-limited and that may only last for a short period of time in their lives and can often outgrow. And so it's important to differentiate those forms of epilepsy that are self-limited versus the ones that have more significant associations with other severe problems. So what I'm going to focus on is, if you look at the epidemiology of epilepsy, both single unprovoked seizures, but if you look at the frequency of either a single unprovoked seizure or epilepsy, which is having two or more seizures, the highest incidence is actually within the first five years of life, or certainly the first decade. And so it's this part of the epidemiological curve that we're going to be looking at. And whereas now we know epilepsy reaches its nadir or its lowest in young adults and adolescents, but now is beginning to increase and recognizing as more common a problem in people over 60. Most of the causes, however, in people over 60 are under this category as symptomatic, meaning associated with something like a stroke, or somebody who has a CNS tumor, or having had an infection, or and certainly in this day and age, accumulation of brain injury or from accidents or trauma, or certainly in the veterans population, traumatic brain injury is becoming a more common cause of epilepsy as a function of age that's cumulative over time. But I'm going to focus on this age group here, where we do have very, very high incidence of both single unprovoked seizures. The most common cause of seizures under between 6 months and 6 years is something called febrile seizures or febrile convulsions, which is not necessarily epilepsy. But I'll talk about that as well. And more importantly, that form of seizures or epilepsy or febrile seizures does not result in long-term epilepsy and is a different condition. So what are some of the facts about epilepsy, and particularly when it comes to children? About 10.5 million children under 15 years of age have epilepsy. Of those 3.5 million of people who develop epilepsy, 40% are younger than 15 years of age, and 80% also are more common in developing countries when we see this in children. What is a seizure? It's important to be very precise about the definition that it's an epileptic seizure is a very specific neurologic event. And we knew that from over turn of the century in the early 1800s was described as a transient occurrence of signs or symptoms due to very specific abnormal excessive synchronous neuronal activity of the brain that we can now identify and measure with a test that we use for diagnosing epilepsy, or the EEG. There's a new definition, actually, for epilepsy and seizures that just came out this year by the International League Against Epilepsy. So epilepsy is a disorder characterized by enduring predisposition to have unprovoked seizures by either neurobiologic, cognitive, neuropsychological, or social consequences. The definition of epilepsy requires the occurrence of at least one clear epileptic seizure, at least 2 unprovoked seizures occurring over than 24 hours apart, or if you have one unprovoked seizure and you have other characteristics that increase your probability of having seizures greater than 60%, is also a diagnosis of epilepsy. And in children, we often have very specific forms of epilepsy, what we refer to as epilepsy syndromes. And we can often diagnose those based on the clinical history, very specific patterns on the EEG, and other features. What's important, and this is a new definition that just came out, particularly when it comes to children, when do you outgrow epilepsy? When do you consider you no longer have epilepsy? And has never been clear, but this is in this new definition. Epilepsy is considered to be resolved for individuals who have an age-dependent epilepsy syndrome and are past that age, who've remained seizure-free for the last 10 years and with no seizures, off of medications for 5 years. So that's, at least worldwide, people agreed on these definitions, and that's pretty hard in this day and age to get that consensus or agreement. So what are the causes of epilepsy? And more so, this is more common in children. We don't use this term anymore. Rather than calling idiopathic means we don't know, we just say it's unknown cause, we don't know the reason. But in children, roughly 70% of the time, the cause is unknown. But in many situations, and certainly in adults and older patients, head trauma is often a significant cause, specific types of brain tumors or stroke. Children, and depending on developing countries, lead poisoning, certain poisonings may be causes. Infections of the brain, either meningitis or encephalitis, may be a cause. There is increasing, as was mentioned earlier in some of the talks, the genetics is becoming increasingly identified as a cause of epilepsy, and particularly when there's a strong family history, specific genes are being identified. And more recently, particularly that is both genetically determined as well as imaging, we can identify some prenatal disturbance of how the brain develops as the cause of the epilepsy. Again, particularly in the pediatric age group, the higher percentage of this unknown type, but we can often identify very specific causes. Identifying the underlying cause is very, very important in terms of making decisions of treatment and types and more importantly, long-term prognosis. When we try to make a diagnosis of seizures or epilepsy, actually the information that I receive from the parents and caretakers, and obviously when dealing with infants and toddlers, they're not going to tell me much what's going on. But very important description of what the event looked like, very specific, what's the duration. And in this day and age, I make a lot of use of video technology, so if somebody can take their smartphone or whatever video device is to actually video events in question, that makes a lot of, is very important for making a determination of whether a behavior is a seizure or not, or is it epileptic. And actually, I'll be showing you many different events on YouTube because that's a source of both poor, but also there's a lot of good information there, if you look at the right source. So the history and exam it probably accounts for 70 to 80% of the time by just a description of the event or actually video of the event. You can often make the diagnosis. It's important to do a very detailed physical and neurological exam. Are there any abnormalities? Because that has an important implications as to long-term prognosis, looking for other causes, doing further tests. And still, the EEG or clinical neurophysiological studies is the mainstay for diagnosis. But we know the routine EEG that we typically do is 30 to 60 minutes in duration, has a yield of only about 60% of the time, or 30% of the time being able to make that diagnosis. But we have other methods to be more specific about that. Neuroimaging plays a key role for identifying some of the underlying causes, and MRI is the imaging modality of choice, and particularly for children because it doesn't use, like CT scan, doesn't use X-ray, and there's no risk of the procedure itself from the MRI. The important thing when we talk about seizures in children is that there are many behaviors and events that we often are referred to as the imitators of epilepsy. So if you look at what's the diagnosis of a seizure, so if you look at sort of Webster's dictionary with the diagnosis of a seizure is a sudden a change in behavior or event that occurs episodically. So there are many other behaviors that may be concerned as being seizures in children, and some of which are sleep-related, so sleep myoclonus. There are startle responses that happen in very young infants. There's something called torticollis, where they turn their head to one direction. That's and other what are called movement disorders, such as tics and chorea, that are not seizures. The most common in infants are related to respiratory problems, either apneic attacks or slowing of breathing, or holding their breath, or sometimes hyperventilation. So respiratory-related disorders can sometimes actually trigger seizures and be misdiagnosed as being epileptic seizures as well. There are also certain behavioral disorders that are sometimes affiliated with sleep, such as, and it was good this is after the sleep talk, because again, sleep disorders are more common in children than is epilepsy and seizure disorders, and some of which can be confused with being seizures, such as head banging as you're going to sleep, something called night terrors or parvo nocturnus, walking in your sleep. So this is the group of disorders that Dr. Cosenza discussed about that are called parasomnias, and they're very specific. And more importantly, children with epilepsy have these more common than the general population as well. So being able to distinguish, are these seizures or do they have both sleep disorders and seizures, is very, very important. So realizing there's many other behaviors that can be what we refer to as imitators of epilepsy, and distinguishing that based on sometimes the description that we get, sometimes the video, the timing of a lot of factors in the history give us these kind of details. When we ask the question if we don't have a good idea of what events are seizures, we do, and often do clinical neurophysiological studies or EEGs. Again, the routine EEG is about 30 to 45 minutes long. We do provocative maneuvers, something called photic stimulation, and in young children, it's somewhat difficult to have them hyperventilate, but actually sometimes when putting the electrodes, they're crying and screaming, and that's a good source of hyperventilation sometimes. And you can often see the changes on EEG as a result of that. But if you actually, the biggest yield of doing an EEG for a question of seizures, if you actually record a period of time during sleep, it actually doubles your sensitivity in terms of helping make a diagnosis of that if a behavior or an event is asleep. But optimally, to make a diagnosis, you would actually want to actually record the EEG during the seizure to be sure that it is, and more specifically define exactly what type of seizure to help make some decisions regarding what further testing to do and what to treat with. So nowadays we have the capability to record EEG for long periods of time. We can do it up to 72 hours at home if needed in the ambulatory setting. We also do this very frequently in the inpatient setting, where we do combined video and EEG up to days if needed to help get a very specific diagnosis. So this is common technologies, and it's important, particularly in infants and toddlers, to really know what type of seizure, if it is epilepsy first, and if it is epilepsy, what type of seizure is it, to help make a diagnosis, and to choose appropriate treatment, and to know what to expect in the long term. So what I wanted to do is actually show you a few examples of things that might be concerned as being seizures that are very common in infants. This is a young infant. It actually gives you...
Okay, Olivia, we're going to have some apple.
That's not uncommon. It's what's often referred to as a shuddering attack. And you see, this would happen during eating, but it happens at other times as well.
Where's that shudder? There we go.
See that kind of shrugging the shoulder?
And
there it goes again. But sometimes that can be very exaggerated over periods of time.
It's around food time.
And the child can look frightened and kind of shaking. But that kind of infant shuddering can sometimes be mistaken as seizures. And certainly seizures in infants can be very subtle, such as the absence or what used to be called petit mal seizures. But these are very, very common, but are often sometimes either called shuddering attacks or benign myoclonic seizures. Here's another example of that, during a mom while she's feeding the baby. See the arm and sort of the whole head shaking as the baby's eating. Again, that's one of these either benign myoclonus or shuddering. Sometimes that behavior can happen as the baby's going to sleep, or at certain points in time to be mistaken to be look to be very violent and be concerned as being seizures. This is another somewhat rare condition that can easily look like what we often see, so-called absence seizures. This is a condition where, if you watch this child, kind of just shaking their head. And what they're trying to do is they often are trying to focus. And if you actually look at their eyes are actually having this what's a behavior called a nystagmus, where they can't focus and their eyes are sometimes going to one direction and then the other. And then they seem to be less responsive during this. And this is something, it's similar to a tic or a movement disorder, or a tremor to some extent, but again, may be mistaken as seizures. And this is an old term that is used to call this something called spasmus nutans. And yeah, so this is, again, a sleep-related disorder that we commonly see in infants and toddlers. And it's actually, they're often asleep at the beginning of this, and then they'll start doing that. Fortunately, they have a nice soft pillow. So actually, this happens. This is called head banging. Some sleep people actually feel children who do this actually, as they get older, might develop restless leg syndrome, and so there may be an association with this kind of involuntary movement. And they're usually asleep at the beginning, and then it happens, after they're asleep. So this, again, is something that may be confused. Okay. So I just wanted to show you just some examples of events that might be misdiagnosed or be concerned as being seizures. But what's important is both from the description, and the most important thing when we try to make a diagnosis of seizures is to be very specific as the type. But the major separation is to differentiate between seizures that are focal or partial, meaning they likely involve one part of the brain, or they start in one part of the brain, or what we see more commonly in children than adults, what are called generalized seizures, where the changes involve the whole body, and on the EEG, the electrical changes involve the brain as a whole. And it's important to differentiate these because the causes are different. What we would do to look at other underlying causes is going to be very different, whereas a generalized form of seizures may be due to some chemical imbalance, or there may be due to some genetic cause, and so there is some increasing studies with genetic studies identifying many underlying genes that cause some of these, whereas seizures that are partial or focal, there may be some underlying structural lesion or problem with the brain in a specific region that's causing the seizures to occur. It can be anything from an early injury. In younger children, if it presents at very young, it may be one of these developmental malformations where the brain developed differently at a certain point in time, causing the seizures. It can be a tumor. So making that distinction is going to change what you're going to be looking for as to what may be causing the epilepsy. And this distinction is based both on the clinical description and the behavior that happens, as well as the EEG helps us differentiate what part are the electrical changes that are occurring. Do they start in a very particular area and then spread and involve the brain? So the studies that help us differentiate these kind are both the clinical description and what we see visually, as well as the EEG. So here's an example of a form of epilepsy that we don't want to ever miss in children, in infants, where this is a 4-month-old boy who was born at term. He had started at about 3 weeks before what he was seen, having episodes where his eyes would suddenly go upward. Sometimes they would turn to the left. Initially, it was just his eye and his head would move, and then all of a sudden his eyes would go up and he'd lose muscle tone. Sometimes he would get stiff and then lose tone with these events. Initially, they were very infrequent, occurred every other day, started happening daily, and then they started occurring in clusters. So what he has is this condition. So what this is a form of epilepsy that's only in infants between 6 months and about 18 months, a condition called infantile spasms. It, again, can be misdiagnosed as other things, but you see the actual seizure is very brief. It's just that extension, and sometimes babies will often have these in clusters. Each seizure is less than a second or so, but this clustering of seizures is very, very common. And this is a condition known as infantile spasms, and is important not to miss. I've seen babies where this has been diagnosed as colic or other problems as well. An important thing in the newborn is because the brain is not well developed, often newborns will have seizures that are very slow. And so you see this is a 2-day-old baby who's having a focal seizure involving just the left side of the left arm, and then the left leg becomes involved. So because of the immaturity of the nervous system, most newborns, if they're going to have seizures, don't have generalized seizures because the brain, again, is not developed enough, and they're often these slower focal seizures that are happening in a newborn that can help you differentiate some of these other types. Here's what some seizures that are sometimes difficult to differentiate from other behaviors.
Allie? It's okay, honey. You okay?
So this is a child just finished the seizure. Now she's kind of trying to get out of it.
Papa?
And then here's another seizure that starts.
Allie?
The important thing is to recognize
she's doing these over and over.
Is that it's affecting her left side of her body more than the other, so it's focal, probably involving the right side of her brain more. But then as it evolves,
how many was that? 5?
It involves both sides of her brain becoming generalized. But the predominant was always consistently on her left side.
Allison? Allison?
And there's again another one that, again, the left arm and the left leg extending during this. These kind of seizures are sometimes difficult. So this is a young boy who just seems like he's perfectly fine, just sitting here, and all of a sudden drops his head. So again, if he was standing, or obviously these are sometimes referred to as drop attacks, and you sometimes see the change in his facial expression, but he's perfect. They're very quick. They go away, and these are very common. We see them in certain forms of epilepsy in children, particularly in toddlers. See, and sometimes they get stronger, and he loses more and more tone. And then this is, I think, a good example of what we refer to as absence, again, one of these generalized seizures. And this is a little boy who's trying to do some homework. And what you'll see, and I think pay attention to facial expression. I think most parents and patients who've seen these. So you see how he suddenly stops and how the change in his facial expression. His eyes look a little more downward. Now the seizure's over, and he goes right back to what he's doing. So this is fairly classic as an absence seizure, and he'll actually have another one here. Now see the change in the facial expression, eye blinking, eyelids kind of drooping a little bit, then it's over.
Okay, so what are you supposed to do today here?
So that's what I just showed you an example of a type of absence seizure. It's rare that that happens in younger infants. This is not a little bit young for absence, but it's a very different form of seizures. And it's important because it's a type of epilepsy that is often self-limited, and children, this is one of the types that a child may outgrow, and differentiating that. And more importantly, identifying this kind of epilepsy, there's only really 2 or 3 medications that work effectively for it, and other medications that we use for epilepsy actually can make this form of epilepsy worse. So it's important to be very specific about the type of seizures and the diagnosis when we're particularly in children. So when we talk about trying to make an accurate diagnosis, what are the things that we pay attention to? Very important is the timing of the EEG. Optimally, you want to obtain the EEG during the actual episode in question. We can, again, obtain EEGs over 24 to 72 hours. The EEG, sometimes actually recording a seizure gives us more specificity as far as the seizure type, but there often are patterns or changes on the EEG that may give us very specific clues or also define the type without actually recording the seizures. And depending on the form of epilepsy or seizure that you're trying to diagnose, sometimes just the shorter EEG, if it shows some very specific findings, may give you the answer, but optimally we often like to obtain it during a seizure, and particularly many forms of seizure we see in infants often happen frequently enough that we can actually record the actual seizure with these studies. And what I wanted to talk with you, and I showed you an example of this condition that we refer to as, used to be referred to as West syndrome or infantile spasms, is a very unique age-specific form of epilepsy in early infancy, usually between 6 months and 18 months of age. It's a triad of a cluster of these spasm-like events that often occur very tightly related to the sleep-wake cycle. They often occur as a baby is awakening or sometime as they're going to sleep, so that relationship is very well known. But what's more important is once infants start having this form of epilepsy, we often see it's associated with a regression of development, so they're losing their milestones or losing their ability to either sit or learn to walk or over a period of time. And we sometimes refer to this as an epileptic encephalopathy because not only are they having seizures, but it's interfering with their brain development and growth. And they have a very characteristic pattern on their EEG that we refer to as hypsarrhythmia that's most prominent during sleep. So it's important that we recognize this, and we have a very strict protocol in our division that any baby that's expected, we worry about having this, is seen here within 2 to 3 days and has a series of studies in a very short period of time. Why it's important, because to make this diagnosis is because there are multiple different causes of it, some of which have important long-term implications, some of which have important issues regarding treatment. And oftentimes we can get some of these diagnoses by the history. Did the baby have encephalitis or meningitis? Maybe the cause of infantile spasms in some patients. Did they have a stroke after a cardiac surgery? Did they have low blood glucose when they were neonates? So these can be just information from the history that might identify some causes that we see for infantile spasms. The physical exam is important. There are certain skin findings that we look for where there's either loss of pigmentation in a condition called tuberous sclerosis, which accounts for anywhere from 20 to 25% of causes of infantile spasms is this condition called tuberous sclerosis. Other conditions that have associated skin findings are important, and why we look at the skin is because the skin evolves from the same part as the brain during development. So the skin cells originate from the same cell type during development, so looking very closely at the skin, particularly in pediatric seizures, is very important. Or there can be very specific changes on imaging that can give us very specific diagnosis that can cause this condition of infantile spasms. Some of these may have specific treatments, particularly if it involves just an area of the brain, such as, or has a tumor. Sometimes surgery may be indicated. But more importantly, in children, and not only with infantile spasms, there's a higher incidence of metabolic, what we refer to as metabolic diseases, or disorders that cause a metabolic imbalance that cause epilepsy. And many of which, though, in the States, and certainly in this state, are actually screened for in newborns when they're born. So actually, this condition called phenylketonuria, or PKU, used to be one of the more common causes of infantile spasms. But now, in this day and age, because every baby is screened for that when they're born and they're treated right away if it's found, they never evolve into infantile spasms or any kind of seizures. And some of these other disorders that are, again, pretty rare, many of those are screened for in newborn metabolic screening. But if they weren't screened for in screening, we would do this as part of our evaluation, because then the treatment is not treating the condition with the symptoms with the medication, is treating the underlying disorder, and oftentimes that resolves the problem, depending on what the disorder is. Some of these are readily treatable, some of them are not. But it's important it alters the treatment dramatically. And more importantly, particularly the metabolic diseases are often inherited, are often recessively inherited, and so there may be risk, if this is their first child, of having other children with similar conditions. So this is a common why we do the kind of studies we do, to look for some of the rare conditions, but also, more importantly, look for treatable conditions that would alter treatment. So what do we happen if we do diagnose epilepsy? What are our treatment goals? I think you heard that from some of our speakers before. We want to eliminate seizures with few side effects as possible. No seizures, no side effects are optimally. And more importantly, we want to help the child and their family lead a full and productive life with treatment as well. I think we often focus on that population of patients that 20 or 30% that don't respond to medications, but particularly in children, some of the epilepsy syndromes are very, very responsive to medications, and children can do very well, such as childhood absence and some of the other conditions. You know, if you choose this drug, there's a high probability that that's going to work. But we're still at a point where it's still trial and error. One of the big challenges, I think, in pediatric seizures, and particularly this age group, is even though we have 16 or 20 drugs, how do you think those drugs are chosen or developed? So those drugs are given trials in adults who have seizures, and they're types of seizures that are not seen in children. And so we can learn a lot about some of the safety aspects of the medications by how long patients have been on these medications. So it can give us a lot of information regarding safety of these new medications, but questions about how effective some of these newer drugs for the particular types of seizures that we see in children, we often have very little information. And so when we make a choice of medications, there are several factors that we look at. First of all, in general, in children, we don't often treat with the first seizure, because many seizures in children can often be provoked, such as a febrile seizure. And so we often will not treat the first seizure, particularly if we couldn't find a cause after initial workup. We also will look at, are there any other factors that would increase that risk of another seizure occurring, such as some abnormality on MRI, very specific abnormalities on EEG, any abnormalities on neurologic examination. All these are factors that increase a risk that another seizure is going to occur. And in children, particularly the forms of epilepsy we see in children, if there's a strong family history, that may also suggest that we should consider treatment earlier than later. When we make a decision about medications, it's important to make a diagnosis as to what type of seizure. First of all, as I was showing you, is it an epileptic seizure or not? Is it some other event that could be misconstrued as a seizure? More importantly, we try to identify a specific epilepsy syndrome. Is there any data regarding the efficacy? And usually, unfortunately, in our age group, and certainly infants and toddlers, there's very often very little data on efficacy. Certainly questions about cost and what is the pharmacokinetic profile. Again, the data we have on pharmacokinetics of drugs are, again, in adults and are very, very different of how those medications may be handled by a child. And in general, we know children have very, very different rates of metabolism of these drugs, and how we change the dosing is very, very different. What are the adverse effects? And are there any other medical conditions that we need to take into account? There may be other medications. So there's a lot of factors we use to make a choice, but the most important is knowing what type of seizure. If there's a specific epilepsy syndrome, then we have a better idea of choices, both what to use and in many cases what not to use that may cause seizures. So as I mentioned, in children, we often have to extrapolate some of the efficacy data from adult studies. It's important to look at the adverse effects relative to efficacy. Also look at other risks of toxicity, such as liver toxicity in children. Particularly, it's highest in children under age 2, where if we're going to consider this drug of valproate or Depakote, the risk of a rash. And there's these age-related pharmacokinetic factors that we're just beginning to look at in some more detail. The newborn is very different than the older infant or toddler in terms of they have low protein bonding, a very low metabolic rate, and also it changes a lot if you're giving their medicines with their formula or their milk as well. And in general, children have a very faster metabolism, and we need to take that into account. So sometimes we give a larger dose per weight in a child because they're faster metabolizers, and then you may want to give in an adult. So that's kind of an overview of sort of general approaches to the infants and toddler. I think as hopefully I emphasize the diagnosis and identifying the particular type of seizure is important, differentiating it from other causes of seizures. And often I have many patients who have seizures who also develop other problems, such as a sleep disorder or other things. So you don't want to keep adding medications or increasing medications when they're having events that you don't really know are seizures or not, particularly episodes that are happening at night. So and fortunately we have the tools now to be very specific and make diagnoses and use the proper medications. Thank you for your time. Any questions? Yes?
We still have a chunk of people on the webcast, so they won't be able to hear.
It seems like phenobarbital is used a lot in infants, and then it's ended as the kids get older. Why? But I can't say for like these specific types of epilepsies, but why would that be for? Yeah,
so again, a lot of that is because of, this is where we're using less and less in phenobarbital, and it should be becoming less. There is more, in fact, particularly when it comes to infant seizures or neonatal seizures, which is, again, a very high risk of seizures, that's the only drug where there's any kind of data is their efficacy, okay? And again, that and phenytoin has some efficacy as well, but there's a lot of difficulty giving phenytoin or Dilantin to an infant. So one of the reasons phenobarbital is used because it does have some data that it is effective, although certainly there are better options, but we have no idea what some of the newer drugs are they going to be effective or not. Certainly in our neonatal nursery, when we diagnose seizures in the newborn, our goal is sometimes we will use phenobarbital, but we use it very, very sparingly, and we usually try to stop the medication optimally when they go home. or sometimes having them on it for a short period of time. And again, a lot depends on what the underlying cause is. Okay, so oftentimes in the neonate, we can often identify the cause as either being related to a small stroke or hypoxic ischemic injury or other causes, and then that's going to be maybe a self-limited process. Okay. Yes.
Where were you?
We have a 6-year-old that we work with, and we're noticing that the seizures have gone from like 5 seconds, 10 seconds to 30 and 40 seconds. 10, 15 seizures a day. Is there a certain time that that the little one just needs to have a nap time or a break time or
Yeah, that's a good
go
point.
home or,
Right.
you know?
Yeah, yeah. So again, I think another important part of treating seizures, not only children and adults, but are there particular triggers? And as we heard about already, sleep is very important. And if it's because that particular child is having a lot of seizures at one point in time because they didn't sleep the night before or their sleep is really disturbed, that's an important factor. Particularly when we deal with seizures that we often are referred to as minor seizures, such as absence. Again, we may not be as aggressive or try to control every seizure because sometimes the amount of medication that it would require to control every seizure has worse side effects. And so oftentimes you try to find that line where you're giving enough medication, particularly if it's a school-age child, so that they're seizure-free during the day. And if they're only having seizures, say, as they're going to sleep, or in a brief time in the morning, then that might be, for that particular individual child, might be adequate. So again, depending on the type, that's why knowing the type of seizure, when it occurring, are there triggering factors. And sometimes those triggering factors are more important to treat than the seizures themselves with medication. And as was talked about with the sleep apnea, particularly children at certain age have a very, very high risk of sleep apnea, and taking care of that sleep problem can cure their seizures. Yeah.
Yes, sir. My daughter was diagnosed with West syndrome while we were stationed over in Italy, and at 3 months old, she was diagnosed. We put her on medication. She was seizure-free for about 6 months, and then when we tapered her off of the medication, her seizures came back. She outgrew the hypsarrhythmia, she outgrew the developmental regression, but the infantile spasms came back. Is there a link between building a resistance to that medication as to why it's no longer effective, or is it just that the spasms are getting stronger?
Yeah, so that's an important point, and I should have emphasized more. So particularly dealing with children under 3 or 5 years of age, you're dealing with a brain that's having major changes as it develops. And it's very, very common that a type of seizure and the type of syndrome, maybe what you see at 6 months to a year, it's going to be very different when they're 18 months or 2 years. And so a child who's having seizures again 6 months to a year later really needs to kind of relook at it as a new problem and reevaluating it from the beginning. Again, realizing that that's having that history is important, but the type of seizure may be very different, and the type of treatment may be very different depending on what's happening at that point in time. So even that first 3 years we changes the rule, and which direction things go is quite variable. And it's not uncommon. Children who've had infantile spasms can develop a completely different seizure type, some that are easily treatable, or some that are a different seizure type or syndrome that may be more difficult to treat.
I was going to ask, on the film of the little boy that had the atonic drop seizures, what does his EEG look like?
Yeah, well, typically it's what we refer to as a generalized pattern, they may have, so children that have drops may have absence, smaller absences, or they may have convulsions as well.
My son has absence, and on his first EEG, he had the generalized pattern and also focal patterns. He's been on medications for a year, and the EEG is still abnormal with the focal patterns. And the very first seizure that I witnessed was not an absence seizure. It was completely different. It was a full-on, like, I don't know. I don't need to go all into that. But my question is, does that lessen the likelihood that he's going to grow out of this?
So a lot of whether, particularly in that condition, is how well they've responded to the first or second medication, and then also more specific, what that focal pattern is.
That's what I want to know, is what that focal pattern is.
Right. So a certain percentage of children who have what we call, classical childhood absence can have a focal pattern at some point in time. That does not necessarily prevent them from outgrowing it. Okay, but again, without you'd have to know details.
Right.
So.
Yeah, exactly.
Yep.
Thank you.
Sure. Okay. Thank you.